And usually we just kind of, on a case-by-case basis, if you have a case, some guys will send us a panel and say, can we use the FTL? Can we use the DICOM? What's the best situation? So we do that a lot, but really that kind of sets the tone for the accuracy in that clinical translation that you're going to have. Another one is that clinical translation, being able to read and interpret what you're looking at from the CT scans and, being able to navigate through the software program. So a few, just for, I'm not sure how many of you use cone beam that much, but this is kind of some of the clinical translations that we've seen where this is tooth number 9, patient is asymptomatic, looking for cosmetic resolution, probing duct is normal, full screening is fine. They took a periapical, there's a slight radiolucent area on the apex side, on that mesial apex side. It doesn't extend over the apex. So most people said, we'll just monitor it, leave it alone, it's really small. The same day, same patient, a CT scan was taken, and there was significant buccal bone loss on the facial. It's just at the coronal level, there was some left on there. So the probing depth was normal. That's why that was normal. But there's a really dense palatal plate, and that gives you it superimposes to the facial, giving you the illusion that there's actually, bone there when there's not. So, the cone beam is not as limiting as what you would get from a pano or from a periapical. And then this particular case was just retreated, and it grew back. But, you could imagine something like this where you wanted to, just extract the tooth and place an implant. You'd be surprised there's no bone, and whatever was left was pulled from that extraction. So it's good to have that visualization. This was an X-ray that was sent to me. It was, so this was, they were extracting the tooth and placing an implant, and you'll notice that, here's the tooth that they're going to extract, and most of the time when you extract it, the drill is going to follow the path of least resistance. Most surgeons tell me they try and redirect to the palate, especially in in that area. But how far are how far do they redirect without compromising that restorative aspect of that? So unfortunately, on this case, the implant did fail. They didn't place it in a proper location or in the ideal location. So the implant's being removed, and then, they're going to graft, and we'll be doing a surgical guide for them. But, it would have been, they kind of wish they would have done that in the beginning, did a cone beam guide for that.
Cindy, there's a question that just in.
Sure.
What box size are you scanning at, and what's the relative Hounsfield units?
So the voxel size varies on the different machines, and we've partnered with imaging centers and mobile units across the United States. And so each machine will scan at a certain size. The nice thing about utilizing Blue Sky Bio is that it does have the capability to bring in very small voxel sizes. And so, a 0.2, is, I know some of the software programs require a 0.4 voxel, but really, you could do a 0.4, you can do a 0.3, a 0.2. Any of those we can bring in and work with. So, it just depends on how big you want your file to be and things like that. But we can definitely work with that.
Okay, and another question, which I'm going to paraphrase a little bit. How do you recommend dealing with scatter?
Okay, so scatter is that's one thing where if we are building that would be something you would want a radiographic guide on. If you have a lot of restorations, they produce a lot of scatter. If the patient's wearing a radiographic guide at the time of the scan and they have the gutta-percha markers, then we scan the radiographic guide by itself, and then scatter has no bearing on how we're going to fit and seat the surgical guide, because we're going to build the surgical guide based on the underside or the intaglio side of the radiographic guide. So, and the gutta-percha markers will show up as long as they're placed below the crown. Then that will allow us to see the gutta-percha markers outside of the noise and scatter. And then when we merge it together, you're going to get something that seats properly, and the scatter is not going to have bearing on the surgical guide that we're utilizing or that we're planning for that.